What's up, guys? It's Dr. Tim Jackson with another episode of the Boss Body Podcast. Today, I have a very special guest. She's kind of like me. She flies underneath the radar, but she is a brainiac. She's a deadlifting diva. She did a year in general surgery. She's kind of certified in everything on the planet. Dr. Suzanne Ferree.
While I make every effort to broadcast correct information, I'm also still learning. I will double check all my facts, but realize that healthcare is a constantly changing science and art. One doctor or healthcare provider may have a different way of doing things from another. I welcome any comments, suggestions, or correction of errors. I take no money from supplement or device companies. By listening to this podcast or reading this blog, you agree not to use this podcast or blog as medical advice or to treat any medical condition in either yourself or others, including but not limited to patients that you are treating. Consult your healthcare provider for any medical issues that you may be having. This entire disclaimer also applies to any guests or contributors to the podcast or the website. Under no circumstances shall any guests or contributors to the podcast or blog or any employees, associates, or affiliates of the Boss Body Podcast be responsible for damages arising from use of the podcast or the blog. This blog or podcast should not be used in any legal capacity whatsoever, including but not limited to establishing the standard of care in a legal sense or as a basis for expert witness testimony. No guarantee is given regarding the accuracy of any statements or opinions made on the podcast or the blog.
Welcome to the show.
Thank you, Tim. I'm so glad to actually get to see you face to face.
Yeah, absolutely. So you, like I said, you kind of fly under the radar, but you are highly sought after in terms of peptides, regenerative medicine. You teach for A4M, IFM, all the other alphabet agencies, the good alphabet agencies. But let's talk about, because you and I, before we started recording, we're talking about neural therapy. So scars, a lot of times we think that they're just, a structural issue. They don't really create functional imbalances. But talk to us why that's not necessarily true.
Well, so it's interesting. Scars are, so let's talk about the fascia in general at first. So the fascia we think is just, or we have thought was just this sort of covering overall. It lives under the skin, under the fat cells, but on top of the muscle layer. And then over all the organs, everything on the inside. So it's sort of this covering over. We thought it for a long time, it was just a covering. And then we discovered that that's actually the sort of information superhighway where things get communicated back and forth all over the body in different directions, not just up and down, but left and right and crossways. It's this beautiful, intricate motor highway for communication for the body, so that the right shoulder knows what the left knee is doing and et cetera. So it also, the way that it communicates is primarily through what we call the autonomic nervous system. The autonomic nervous system is fight or flight and rest and digest. And everybody's familiar with that kind of concept because we often live in this fight or flight state as adults, especially since we had the big virus a couple of years ago. So this fight or flight state can affect all kinds of things. And the research is coming out now over and over and over. Almost every day, there's an article coming out showing that this sympathetic or fight or flight dominant state is one of the leading causes of sort of the root cause of a lot of our disease in general. So not only the reason we have trouble getting over Lyme disease, the reason we have trouble fighting off mold, toxin exposure, but also it can be the reason why we end up developing things like high blood pressure, heart disease, liver and kidney disease. And so it can be the basis for a lot of those disease states. And you may not experience it as stress, for example. You may just experience it as chest pain or as high blood pressure that you don't even know exists until you begin delving in or you actually go see your provider. So this therapy, we know that if there's any sort of trauma to the fascia, either from an injury or from a psychological injury. So there can actually be trauma to the fascia due to a psychological injury where the tissue doesn't recover as well. There is a vasoconstriction, and I don't mean where the limb turns blue. I just mean where the tissue doesn't get quite adequate blood supply. It gets unfavored, becomes unfavored over the surrounding other tissue. So the decrease in blood supply can, of course, cause problems because now you don't get the nutrients that you need. The cells don't get the energy that they need to do their job. They don't get the ability to remove toxins quite as well. So the cells become the tissue becomes a little bit more acidic, and creates this problem where the cells aren't functioning optimally. We know that a healthy cell has a millivolt a charge on the cell, sort of like a battery, of about -70. And when that tissue gets damaged, that cellular cell membrane potential goes down to around -40, which affects the ability of the cell to receive nutrients, to get rid of toxins, etc. So when all that happens, we end up with trauma in an area, and particularly of that fascia, which sends a message up to the brain through the autonomic nervous system saying, oh my gosh, the sky is falling, kind of like Henny Penny. If we can interrupt that pattern by using just a very small amount of precisely placed procaine we use specifically, it's in that local anesthetic category, but as opposed to being just a local anesthetic, and as opposed to the other anesthetics that are similar to it, like lidocaine, bupivacaine, ropivacaine, tetracaine, those are all a different chemical altogether. Lidocaine itself has a couple of really cool, procaine has a couple of really cool metabolites that actually do the work we're trying to accomplish. So it creates this, what we call an irritation pause when you inject procaine into a scar, for example. It can create this irritation pause where this fight or flight response gets turned down temporarily. We don't want to turn it off completely, because we need to have that beautiful balance between the sympathetic and the parasympathetic nervous systems, the fight or flight and the rest and digest. But what we would like to turn down that sympathetic so that they can be in balance instead of this sort of dominant state. You can do that with vagus nerve stimulation. You can do that with procaine injections, and we try to encourage people to do both. So that local injection specifically placed of procaine can both restore the vasodilation, or the normal blood flow to that damaged tissue. It can also change that cell membrane potential from that kind of weak battery, -40 millivolts, to this really nice supercharged battery. Now the cells can function better. They can get rid of the things that they're exposed to and function how they need to. So super exciting. And it's been one of the bigger game changers in the last several years in our practice. So it's exciting to have this new tool in our toolbox.
And that is what you mentioned with the voltage. That's basically the way I explain it to people. And that's the premise behind PEMF, or pulse electromagnetic field therapy, correct?
Correct.
And so when people come in for scar treatment or neural therapy, does it depend on the person and the age of the scar in terms of how many treatments they need?
It does. It depends on the severity of the original trauma. So, for example, we had a client who had over 40 years ago had a traumatic childbirth, where her xiphoid process was fractured in the childbirth. And we treated her with neural therapy in various other ways prior to discovering this. When you do a neural therapy physical exam, you're looking for points of tenderness and scars that people forget about, because everyone forgets. Oh, yeah, right. I had that mole removed, or I had that whatever. And so we do this very pointed exam of all of their skin surfaces. And the nurse practitioner who was doing her exam found particular tenderness at her xiphoid process. With treatment of that xiphoid process, she had immediate emotional release, which is crying is a release or a processing of the previous trauma. And so she had a release of that previous trauma. And then she actually had resolution of that pain, because after that, having been treating that. So some patients, one treatment is all it takes. It really just depends on the patient, how long they've had it, how severe the trauma was to begin with, and then the intervening things that have happened since then. And then how much of that particular trauma was related to a sympathetic dominant state, and does actually have the change in the cell membrane potential, as well as the vasoconstriction of the area.
Can you see improvements in HRV with the neural therapy?
It's really fascinating that you ask that, because we definitely do. So patients who wear their Aura rings will send me photos of their changes in their aura ring. Yeah. So it'll go from around, a 30 to 40 up to like a 60 to 70 after having received neural therapy that day.
I use, are you familiar with the Hulis device?
No,
So I learned about it. Do you know Ryan Cedarmark in Atlanta?
I don't. Mm-mm.
He's both a chiropractor and a nurse practitioner, and he
Interesting.
works. I think it's Brain Rehab Centers of Atlanta,
Oh, yeah.
most of the time. But then one day a week he's with an orthopedic surgeon. But he told me about it, or brought it to him because he does chiropractic neurology, and he said, "Yeah, I've been using it on myself and using it on patients, and I've had mine for about 9 or 10 months. I love it. It's made by a doctor of biomedical engineering. You just apply it right here. Has 5 different modes." And instead of the Apollo Neuro, which you have to wear for a couple hours, this is like 2 minutes, 1 to 2 minutes, 3 times a day, and it literally
Wow.
fits in your pocket, and it works. I can attest, because a lot of the devices that claim to work are kind of under deliver in my experience, but the Hulis definitely works. So I imagine if you combine it with something like the neural therapy, outcomes will
Right.
be better.
Does it have to be put on your skin directly?
Yeah, it does.
Okay.
And the only thing, it's not a subscription model. It just has the 2 little silicone electrodes that go in there, and they send you like 2 jars when you first purchase it. But I think they offer a 60-day money back guarantee, so there's really no risk. Um, and I've had nothing but positive experiences with it. And I don't track my HRV because I don't really wear the wearables like I should, because of the non-native EMF. So it's kind of a catch-22 with that. But I can definitely feel the coolest working for sure.
Well, the aura is only it only produces EMF when it is near your phone.
Oh, okay.
So as long as the app is off on your phone, it's not transmitting any data. So that's one of
Okay.
the reasons why I like aura. You know,
Okay.
Mhm.
And so that's your preferred wearable.
It is.
And the neural therapy, so there's not really any physical changes in the scar because the scar is formed, right?
Oh no, we've seen scars flatten out.
Oh, really? Okay. Okay. I
Yeah.
thought it was more just correcting the interference field.
So you do, and I think because you're restoring blood flow and you're improving the cell membrane potential, I think that's why we end up seeing some improvement in the appearance of the scar as well.
There's better hemodynamics,
Mhm.
improved autonomic response, so better HRV, parasympathetic, sympathetic, yin and yang balance. So there's a lot. And what on average is the cost? I mean, we're talking 10,000, 30,000
Oh no, it's
dollars.
way less than that. So the course of therapy is probably going to run you around 5 to 10, depending on how many treatments that you need, how long of therapy that you need. Procaine is very inexpensive, and the treatment's very inexpensive. And the if I think that I think you can get this. You can expect around a $5,000 to $10,000 course.
Wow, that's impressive. Because I've read a lot about the neural therapy. I haven't had it done. I know, well, you and a couple other people who do it, but we were talking about Dr. Klinghardt. So a lot of my listeners and viewers are familiar with Dr. Klinghardt. Peptides. So you're also known for peptides,
Mhm.
which I've been dabbling in for 5 to 6 years. What got you into peptide therapy?
An injury. So I was a competitive runner, and I went to I started doing. I got a condition called Trendelenburg, where your
Yeah,
glute doesn't
yeah,
turn
glute medius.
on.
Yeah.
Exactly. So I'm running, and I injured my hamstring because when you're pulling with the hamstring, trying to run long distances, that's not the way to do it.
Right.
So because of poor form, I injured my hamstring and could not run anymore. So thankfully, that's what led me into doing powerlifting, which was great. I'm glad for that opportunity. But at the time, and it led me into peptides. So grateful for the injury. I
Yeah.
went to an A4M conference, and they do those breakout sessions in the
Uh-huh.
afternoon. And so at the conference, one of the breakout sessions was on mechanic growth factor. And I was like, what is this magic sauce? Oh my gosh. So I went to a intro to peptides course and started doing all this research and deep diving into what's available, which was so great. There's so much out there that who knew was there. So it's been really a fun journey to learn about it and then to share that with everyone and to be able to help a lot of patients kind of move the needle again. You know, you feel like every time you learn, I remember when I first learned just bioidentical hormones. I remember, and I don't mean just, it's huge, but I remember first learning bioidentical hormones and this huge swath of patients got better that hadn't gotten better for years. You know, these women that I was treating with antidepressant medications who didn't have a Prozac deficiency, they just had an estrogen deficiency, right? We just fix them, their hormones and balance them out, and wow, their mood disorder gets better. So that was really exciting. But there was still this segment of patients. And I think that's what you primarily see now too, is this sort of chronic disease, chronic underlying infections category of patients. And when you treat those patients, you look for, okay, what's the next thing? Okay, what's the next thing? Because the next thing doesn't work for everyone, and the next thing doesn't work for everyone. And that little category of sort of chronic underlying infections seems to be the most elusive that we chase. Many of them get better with just fixing their hormones, but often they need an additional perks. So this was one of the keys for me for helping to move the needle along. And then adding neural therapy on top of that was it allows the cells to receive the peptides, to receive the metenkephalin, to receive the alpha lipoic acid, or whatever it is you're trying to help the patient adjust. It's one of the things, it's often one of the things we'll do ahead of time. We'll just do an IV of procaine and the patients are able to receive whatever we're giving them otherwise.
Yeah, it's like I say, you can't have an erection. Well, this is what I tell my male patients. You can't have an erection when you're running from a tiger or a dinosaur. Sympathetic
Correct.
dominance, you can't receive. It can be the most positive thing. It can be liquid gold, and
Yep.
it's not going to work. But
Did
going
you ever
back to
read
your
that
example,
book? Did you ever read that book, Why Zebras Don't Get Ulcers?
Robert
I
Sapolsky,
love that book. It's so good.
it's amazing. Yeah, it's great. And I just interviewed someone the other day who I think she was at Stanford, or she met him at Stanford. She's a double board certified anesthesiologist, pediatrician, but now she just does acupuncture. Not just
Wow.
acupuncture, but she cured her allergies with acupuncture and she went to Spain and trained. So, bit of an overachiever. Back to your orthopedic example. So, the reason I got out of orthopedic rehab is if you look at people with bilateral knee pain, the synovial fluid, mycoplasma antigen antibody complexes. So I'm like, I can manipulate your joints. I can do active release technique. I can do Grafton. I can do classical laser. It's not going to do anything unless you address the pathogens because it drives up MMP9, which eats up your collagen. And then, the orthopedic surgeon will be happy to go in and do a total knee replacement. You'll never have a normal gait pattern. So I pissed off a lot of orthopedic surgeons, but I'm like, hey, they would say, why are you working on this person's hip when it's their knee? I'm like, what's that bone? The femur. Why would you ask me that? What's that bone? The femur. There you go. It's the same bone. What a
Yes,
novel
yes.
concept. Like you
So
said, but go ahead.
we use procaine and ozone in the joints to
Okay.
try to improve their lipopolysaccharide and or their chronic underlying infections. Then you can add a little bit of the small molecule pentosan polysulfate 54 to get that MMP9 down. So you're sort of hitting it from all the different directions. And then we add some peptides into the joint as well. There's only a couple that have some interarticular research using them, but they work really well. So it's kind of exciting.
Is BPC 157 one of the ones you do directly into?
It is. I haven't tried yet. There's a research study demonstrating benefits of liraglutide, which was the precursor to the semaglutide that everybody talks about, the Ozempic that everyone's on.
Mm-hmm.
But the liraglutide was the original. Victoza is the brand name. But the liraglutide has a study in humans doing interarticular injections for osteoarthritis. So I haven't tried it yet, but it's fascinating and it certainly makes sense. If you're improving the way the cell can make and use energy, why would it not apply to chondrocytes as well?
Right.
Mm-hmm.
And I'm guessing you're probably either you know of or you're friends with Dr. Kent Holtorf.
Sure. Mm-hmm.
Yes, I had him on the show. He's really difficult to get in touch with. I usually have to go through an assistant or a staff member, even though I have a cell phone number. But he's a really cool guy, always traveling. But he got me on to, peptides and the peptide bioregulators. Do you do much of the bioregulators?
Yes, yes. I'm actually teaching 2 weekends on peptide bioregulators at A4M.
And I think I saw that Dr. William Siege, you work with him, right?
I have in the past, yeah.
Okay, I call him the bow tie doctor because I used to take
Yeah,
his what's it called? DHHB, dihydronochial B. Um,
exactly.
I don't think he makes it anymore. I'm not sure. But
Mhm.
what's this? Is it SSRP?
Yes. Hmm.
Yeah, the cellular medicine. So you're kind of all over. You must not have a lot of time to stay home, be with your family if you're
That's
traveling and
interesting.
teaching. And
Hmm. Yep.
yeah. So we talked about peptides in general, but mitochondrial peptides, MOTS-C,
Hmm.
SS31. When would you choose one over the other?
So I think of SS31 in the chronic disease state. I think of MOTS-C in the athlete weight loss. That's not exactly true because there's a lot of crossover if you're talking about mitochondrial health, but I think that's where I've seen the most research. SS31 has the kidney and heart disease research, and that's where I sort of niche it. It also is a lot more expensive than MOTS-C.
Okay.
So that's kind of where my brain goes with categorizing them. You're doing a little bit of a different, you're really doing that, you're doing that calorie restriction mimetic effect with the MOTS-C. You're really doing the helping the mitochondria to function optimally with the SS31. So, like I've given it to my dog who has kidney disease and the SS31. I have a patient with chronic congestive heart failure. She takes SS31. So that's how I think about SS31. Although, again, there's a lot of overlap between the two, and you can use them in conjunction because they work slightly differently. Now, keep in mind, you want to be cautious about making sure that the patient is optimized as far as all of their nutrients go, because if you're
Right.
running up their mitochondria, but you're not giving them the nutrients that their mitochondria need to function, now you're creating diseased mitochondria, you're creating mitophagy, their cellular, decreasing cellular health overall. So this isn't really what we want to be doing, is over stimulating the mitochondria. But I think that they're both really great options, and I'll leapfrog them often. So we'll do one and then flip to the other one.
Do you use them concomitantly with NAD?
So in some patients, I'm a little bit guarded about using them in my older patients because of senescent cells, or risk of cancer. You're going to be running up. If you give patients NAD, you're stimulating all of those things to giving energy to all of those things. So much like I think about a lot of the peptides, I'm going to be cautious about who I'm giving them to, because you're going to, what am I triggering? What else am I triggering to happen? Right.
Right. It's kind of like, well, I know with thymosin alpha 1 and thymosin beta 4, obviously they're both good for immune function and anti-aging because those are two sides of the same coin. But TB4 stimulates angiogenesis, correct?
Mhm.
So
So
you
does
have to be
BPC.
right. So you have to be careful, really careful in people with cancer if you already have the cancer, correct?
So there's no studies that demonstrate that thymosin alpha thymosin beta causes cancer. There's no studies that demonstrate that BPC causes cancer. These are all theoretical risks because we know
Right.
we're increasing blood flow. If we increase blood flow, and we also change the immune response, are we helping to kill off the cancer? I don't know the answer to that. And so there's people that are way smarter than me that are doing that research, and I'm just following what's happening there.
Gotcha. Yeah, I was curious because my thinking was, if you already have cancer, then be careful with TB4, and just, from a medical legal standpoint. But outside of that, I mean, it's counterintuitive because people will say, oh, well, I can't take that because I have an autoimmune or neuroimmune disorder. I'm like, I know, you just got to trust me. Like it works. It's more like an adaptogen for the immune system, right?
Absolutely, absolutely, especially the thymosin alpha 1. So I use thymosin alpha 1 in a lot of my clients with autoimmune diseases, for that very reason, exactly what you're talking about. It only does what the tissue needs.
Right.
It's going to adjust its performance characteristics based on what that cell, so the cell will respond to it based on what it needs, which is really cool, I think.
Yeah, absolutely. What would you say your favorite peptide is?
That's a hard one. Uh, I use a lot of BPC. I feel like AOD is the underdog in a lot of these fights because it doesn't get as much attention. I love using AOD, but I have to go with a growth hormone secretagogue. Probably testosterone is my favorite one because it's already FDA approved, so there's not a lot of trouble there. Two, because it's 24 hours long, fairly long acting. Three, because most patients come back to me saying, wow, I feel so much better. Wow, I notice a difference. So I think that has to be the front runner because of patient benefit, even though there are lots of great stories with other peptides.
I know back in the day, I think it was 2013, I tried Sermorelin, which I think only has a half-life of like 2 to 3 hours.
Right.
So you should basically inject it at least twice a day, which I mean, ideally 3 times a day. And it's still, I didn't notice much of a benefit. I take 1 milligram of genotropin at night.
Yes.
So well, you probably know them. Don Dennis and David Robertson.
I do. I know Dr. Dennis for sure.
Yeah. The Dennis Robertson syndrome with mycotoxins colonizing.
Mm-hmm.
Yeah. So that's how I got my insurance to approve the genotropin.
Nice.
But so David Robertson, I see him for that. But when you have a patient come to you or a client come to you with chronic infections and autoimmune/neuroimmune syndrome, how much killing do you do versus modulating the immune system?
So I think you have to fix the immune system first. You have to fix their detox pathways first. So, this is one of the things that we unfortunately didn't listen to for a really long, let me say, I didn't listen to for a really long time from our naturopathic partners and now allies, I hope, because they always start with the gut. So we're always working on making sure their detox pathways are open and ready and able to remove things. We can help with that in a lot of different ways. And so we'll start there and then we'll modulate the immune system so that they are able to respond appropriately, respond and then turn off, right? That's one of the things we see, like with galectin-3, for example, they're not turning off that galectin-3 response, that alarm and response. Or the complement when you're talking about mold and Lyme, they're turning on but not turning off that complement system. So and we think of long haul COVID too. So if we can modulate that immune system to respond appropriately to an invader or an offender or PAMPs and DAMPs, then we start working on pathogens. And I think the body, and oftentimes you don't even need to do the pathogens because now you are seeing that patients respond. There are a few cases where you have to start from the other end because unless you get at least some control over or some diminished number or volume of invaders, then you can't even begin to work on the other things. And so there are ways we can look at that, and so we'll sort of address from the opposite end depending on the patient and what their body needs.
And that speaks to the cell danger response, right?
Correct.
You can either produce ATP or you can it's like the fight or flight response for the mitochondria, essentially.
Correct, which is why we almost always start with procaine.
I'm sorry?
With procaine.
Procaine. Okay, gotcha. Absolutely. Yeah, so everyone in your office must, instead of an insulin pump, just need a procaine pump, just to say, chill out. I always say, the best business model would be to have a GABA car wash. If we sprayed everyone down with L-theanine GABA, or, we had a spa and instead of just the regular facials, we put some GABA L-theanine cream lotion, like people would be lining up around the block, I think. Especially in Atlanta where traffic is, that's enough to spike your cortisol right there. LL37, talk to me about it.
So one of the problems for me with using LL37 now is that there are a lot of bugs that are resistant. So it's awesome because it is a naturally occurring peptide, right? It's a cathelicidin that comes from the intestines, triggered by the presence of or by comes in response with vitamin D. So this is awesome. We love using LL37. However, because of a lot of resistance out there, there's not a lot of it's less and less useful now. We'll sometimes use that directly in a wound if patients have been exposed to have had a tick bite, for example. We can inject that directly around the wound itself in sub-Q. And we'll use that sometimes in conjunction with other things, just to be addressing all of the factors. If I'm treating intestinal health, I'm probably going to start with things like rectal butyrate. That's, people joke that that's my favorite drug to go to drug, but it is, and it works, and patients get better. And so that's where we'll start. And sometimes we'll do that in conjunction with LL37, with the idea that I'm decreasing pathogen load. And of course, it depends on what you see on your GI map. It depends on, or your Genova GI effects or whatever you're using. And so we'll address that with something like that. It's a little bit less pleasant to do the rectal butyrate, but we do it in suppositories now, so it's not quite so stinky. The compounding pharmacies aren't huge fans of us for that, but
Yeah, I love
apparently it stinks
butyrate.
up the whole pharmacy.
Great for metabolic health, even decreasing systemic inflammation, blood glucose.
Oh yeah.
And it's part of, the Patricia Cain protocol for neuroimmune syndromes, mold toxicity, Lyme. So I'm guessing that's another reason why you like it.
Oh yeah, absolutely. It's really, it's got so many. There's that great article that came out that Dr. Seeds was part of in 2020, that was talking about treating COVID with butyrate. But it really is it's a very thorough study of all the benefits of butyrate in general.
Okay, awesome. So LL37, you're not as big of a fan anymore. When did you start noticing resistance?
Probably 5+ years ago.
Gotcha. Okay, so how long have you been doing peptides?
10, maybe 10 years now.
Wow. Okay. Yeah, wow. I don't think I did my first round of peptides till like 2017. And I think my first one was TA1 and TB4.
BPC.
But we were talking about, what's that?
BPC, that's what we all did. TA1 and BPC.
Yeah, exactly. And I don't know if you've read the book, but The Immunity Code, Joel Green. That guy, he's a smart guy. I had him on the
Pretty
show.
Smart.
Yeah. And, he's 60 and he looks like 35, 36. He knows his stuff, but I'm not sure why I thought Joel. Oh, because of the immune system and, just talking about the different populations in the gut and feeding the bifidobacteria. If you feed bifidobacteria and Akkermansia, you're basically feeding everything through the cross shunt or butyrate shunt. But yeah, I think butyrate is great for cognition. It can even raise BDNF, brain-derived neurotrophic factor.
It's great.
So
one of the coolest things that I learned about the intestine is how that environment inside the lumen actually needs to be hypoxic, because that's what your Akkermansia and your bifido are. That's what they prefer. They're facultative anaerobes. They prefer an environment that has no oxygen. So if you are if you're taking plenty of fiber, then those guys get plenty of fiber to eat. They convert it into butyrate. That's your intestinal epithelial cell's favorite food. They take all the oxygen from the environment and use it to make energy. That's a perfect world where everything's working fine. Now let's say you take 3 days of antibiotics, or you get a colonoscopy prep, or you get a stomach flu, or you have a traumatic brain injury, or you get some sort of intestinal inflammation from emotional stressor. Now you've completely disrupted your microbiome. And there's not enough bugs to take the fiber and make butyrate. So now the cells begin to dump oxygen into the lumen and nitrates into the lumen, feeding those bad bacteria. And so the problem is this hypoxic environment now becomes not hypoxic, and now we have no bugs that work or symbiotic in a symbiotic way, and now we have bugs that take all of our nutrients and convert them to toxic metabolites. So it's one of the reasons why I love fiber and butyrate, and maybe it maybe makes me question the use of rectal ozone, because if you're introducing oxygen into that environment, you may be creating more trouble. So I don't use the rectal as much as if I don't really have to.
I was going to ask you, so when I was in North Carolina, the clinic I was working in, we had 3 hard chamber hyperbaric units. And
Mm.
so I did 80 dives at 2.8 atmospheres. And I took probiotics, but I still noticed some GI upset. What sort of negative consequences does it have? Because, 98% or more of the microbiome is anaerobic. So,
Correct. Yes. So if you're in a healthy state, yes.
yeah.
So again, I'm not sure there's been a study done on this, but we can just say what we understand to be true is that that lumen needs to be hypoxic. So how do we restore that hypoxic lumen? And I think the answer is rectal butyrate and oral fiber.
Gotcha.
And then
Yeah.
fermented
And
foods and all the things to restore your microbiome.
do you deal with many patients who have mast cell activation?
Sure.
I mean, the question, like Dr. Jill Carnahan says, the number one trigger for mast cells, mycotoxins, number two, Lyme and co-infections, then psychological stress. So, I mean, I like ketotifen in the short term. I know it's not a long-term solution, but it allows, if they're reacting to lettuce or, something simple, then how do you feel about mast cell inhibitors?
Yes. So what about procaine as an antihistamine?
Oh, okay. I
Yeah,
need to sign up for the Dr. Suzanne Ferree University.
there's some fascinating information about it. Yes. So our next course is July 18 here in Atlanta.
All right.
Mm-hmm.
And you can sign up on your website.
Yes.
All right. Um,
That's
I was looking.
vinemedical.com.
How, because I know you used to teach medical students. How did you teach them integrative medicine?
So I started to at the end. I taught, I believe, for 11 years through Emory University. And as I incorporated more and more integrated medicine into my own practice, I was teaching them, of course, this is a different way to think about things. And by the end, it was too difficult to teach them the things because they weren't learning what they came to learn.
Right.
And there were only a few that were actually coming with the intention of learning integrative medicine. So,
Right. Yeah, I imagine because I know a lot of people that they want to teach or they have taught, and then it just gets to be awkward because you know you're trying to ride 2 horses with one behind, essentially.
right.
So procaine, mast cell inhibition properties. So if someone has significant mast cell activation, can you do, I know you said IV procaine, but can you do oral?
Uh, I think I would probably do it IV, but I would pair it with a really healthy intestinal program.
Okay. Yeah, because then you got DAO in the gut. And so if you're not degrading histamine in the gut, then that could be problematic. Any other peptides that could help with mast cell? KPV, right? Can help.
Correct. Correct.
Okay. What are your thoughts on KPV?
Yeah, I'm a big fan. I appreciate it. I enjoy it. It depends on the reason why they have mast cell. Mast cell itself is not always the cause. Mast cell is
Right.
often the symptom.
Right.
Mm-hmm.
Yeah, I agree. I mean, sometimes people say, "Oh, I can't take ketotifen; it's going to cause Alzheimer," and I'm like, "Well, have you taken Benadryl? I mean,
Yes.
you're not going to stay on it for like 8 years. I hope not. But if it's lowering acetylcholine, it's going to increase the risk of Alzheimer's. But like you said, you got to get to those root causes, and could be trauma stored in the fascia. Let's go see
Correct.
Dr. Suzanne for that. I probably need to come see you. And then, yeah, because I remember I got to there's 5 universities in the US where you get to dissect a cadaver, a human cadaver, as an undergrad, and Wake Forest is one of them. So I was spoiled. They bring a male cadaver and a female cadaver from Bowman Gray Medical School over. And I remember the fascia is the first thing you see. And so the fascia, what all have you learned that's really surprised you about the fascia that you didn't know, say, 5 years ago?
I think it's mostly about the autonomic nervous system endplates. This really is a communication superhighway for neurotransmitters and the nervous system to communicate with the tissues, with the organs in general.
So it's like
I
the
don't,
internet of the body.
correct. I really didn't think that, I didn't realize that it was anything more than just a covering, and to realize that it is a communicative structure that is so critical for that whole body communication.
Yeah,
Mhm.
and I think that's sort of a reoccurring theme. I remember back in the day, they used to say adipocytes were just structural. There was no functional role. But now, I
Mhm.
mean, for the past 15 years, we've known they release inflammatory cytokines, adipokines. So rarely is anything just structural, right?
Mhm. Mhm.
Um, Hormones. Do you start? So let's say someone is 65-year-old female, you know she's going to be low in progesterone and estrogen and probably testosterone. Do you start with hormones? Do you start with mitochondrial function since that's more extreme?
So it depends on what I find in their labs, what in their results. It depends on what their symptomatology is when they come to see me in the first place. So often we will start with hormones because that's what they're coming to us for. So we'll
Gotcha.
say, okay, I can see why that would be something that would be interesting. Let's fix your gut first. Let's so that we know your detox pathways are open, and then we'll give you the hormones and see how you respond. Of course, I'm going to treat someone who's 65 with a way lower dose than I'm going to treat someone who's 45. We're going to then follow them up with to make sure their detox pathways are working post treatment, that they're clearing the medications as we give them, of course. And then we're going to say, okay, how is your body responding? Because a lot of women will respond, and men too, I'm sure, will respond so well to just getting that estrogen back on board, because you know that estrogen can be that second trigger in the inflammasome. So if you've got your pamps and damps from whatever illness or injury you had remotely, and now you have a drop in estrogen, now you're triggering that whole inflammasome response and all that tissue damage that's occurring because of that. Be back to when you were 20. If I just get them back to
Oh, sorry,
50,
you froze. Can you repeat what you said like 30 seconds ago?
sure. If you can just get them back to, I'm not going to try and get them back to when they were 20, but if I can get them back to at least where they were 50 or 55, then we can actually see their body start to turn back on all by itself with just a little bit of estrogen. It's really amazing to watch.
Yeah.
So, and of course, we're talking about bioidentical hormones. We're talking about topical or alternate, not oral administration. I mean, there are some people who need an oral, and that's a whole different conversation. But in general, we're talking about bioidentical, topical, or injectable or whatever, not oral hormones, and not the ones that are commercially available, and not the commercially available hormones. So if we're using proper hormones and we're using proper doses and we're monitoring them for response, and we're starting out by doing things, opening detox pathways, then these people often will respond with just giving them hormones alone. Then we add on top of that things like peptides, like procaine treatments, like whatever, looking for other disease states. And certainly if they're showing up with some oxidative cellular stress, and there's really simple, easy ways we can look for that. A reverse T3 is going to tell me that a high reverse T3 is going to tell me that they're probably having some cellular stress. If they have a high OxLDL, that's probably some high cellular stress. So in those cases, sometimes it's as simple as a nutrient deficiency. Maybe they're zinc or iodine deficient or selenium, and we can simply replace that. Sometimes it's something like a molybdenum deficiency, and that can often be related to a chronic underlying infection. So, you run down these rabbit holes with these patients, but a simple way that a lot of people respond to is just starting with some extra estrogen, or removing. In a lot of our men who come to us, they've been on high testosterone, they've been on testosterone replacement, they've had their estrogen suppressed so low that now they're fatigued and they're having trouble getting motivated. And my testosterone used to work, but it doesn't anymore. And so the initial thought is, oh, this is probably mitochondrial. But what if it's as simple as we've suppressed their estrogen too much and they don't have the capacity? So now if we just take the brakes off and removing their estrogen blockers, wow, they really start to improve, or not even remove, just decrease the dose.
And these are guys who's been on aromatase or anastrozole?
Correct. Yeah.
Gotcha.
Something like that. Mm-hmm.
Do you automatically give guys who go on TRT on aromatase inhibitor like a prescription, or do you use things like resveratrol?
We're going to use that. We're going to use Dimini 3C. We're going to do, that's a great choice. Alpha lipoic a great choice. Just trying to get them, again, opening up pathways, helping them with their oxidative stress. It's the oxidative stress that's the problem rather than the testosterone.
Right. Yeah. And the other thing, I mean, even lipopolysaccharides, you've seen the studies where they can go to the Leydig cells in the testicles and turn off testosterone production. So inflammatory cytokines, interleukin 6, TNF alpha can absolutely interfere with your hormones. And I mean, a lot of guys feel better as soon as they go into testosterone, but some don't.
Mm,
And, it's more root causes. And even if you don't feel better, if you fix those things, you're going to need a lower dose, I think, right?
correct. And that fascinating study that came out fairly recently with TA65 or the astragalus, talking about exactly what you're talking about is restoring function with using something as simple as an herb.
Yeah, absolutely. So it's definitely, we can tell you're a lifelong learner. What's something you know today that you didn't know in, say,
Oh,
2015?
gosh, I was just having this conversation the other day with a client about how you tend to feel there. You could certainly go back and look at yourself and say, wow, I can't believe I mean, I put every single menopausal woman on Prempro back in the day. And when I think about that, it just breaks my heart. I didn't know there, and that was
Right.
what was out, the information that was available to me at the time. So I'm so grateful for that. I don't think I grasped the distance, the time distance between bench medicine and clinical medicine. And so I'm grateful for also for the time that we've had with COVID, because that's sort of gotten to be light years faster since then. It used to be 20 years from a discovery to showing up in the doctor's office. And we just used to wait around for the drug reps to come and tell us how to treat things. And I mean, maybe you didn't, but I did. And so when the scales finally fell from my eyes and was able to see, wow, there's so much out there I had no idea. You can't ever unsee it. And I think the kind of last thing that I've learned is how much of our physical health is related to our emotional health. And how so much emotional trauma gets stored in our bodies, and it gets stored in a chemical and physical and electrical way that can be released with chiropractic care. It can be released with breath work exercises. It can be released with things like Graston technique, lots of things, procaine therapy, as far as I'm concerned. I think there's lots of ways we can release that. And it's exciting that we have so many tools in our toolbox now to help patients get better.
All right. Well, thank you so much for your time. Where can people find you? We're going to put the links up, but it's vinemedical.com.
Vine is in grapevine, medical.com. And then I'm on Instagram at Dr. S. Ferree.
Yeah, because I think when I started following you, like one of the first videos I saw was you deadlifting. And I was like, man, I do not want to get on this lady's bad side.
Yep. That was fun. That was fun.
Oh, looks like you got it. What kind of doggy is that in the background? That's a dog.
She's the best kind. She's a mutt. That's Natasha.
Oh, oh.
She's ready to go home.
Yeah, it's hard to be in a bad mood if you're a patient and you see a dog, right?
Exactly. She's our therapy dog supervisor.
Well, thank you so much, Dr. Suzanne, and we'll be in touch.
Thank you, Dr. Tim. So nice to spend time with you today.
Absolutely. Have a blessed day.
Take care.